Welcome to the Culture of Healthcare, Ethics and Professionalism. This is Lecture C. The component, the culture of healthcare, addresses job expectations in healthcare settings. It discusses how care is organized within a practice setting, privacy laws, and professional and ethical issues encountered in the workplace. The objectives for ethics and professionalism are to discuss foundational concepts in medical ethics and professionalism, examine the relationships among ethical ideals, professionalism, and legal duties, apply the general principles of ethics and professionalism to specific topics, and examine ethical issues in health informatics. This lecture discusses contemporary topics in medical ethics. It provides several examples and top-line descriptions of some of the complicated issues that healthcare professionals face. This lecture focuses on informed consent, end-of-life issues, conflicts of interest, healthcare disparities, and conscientious objection. Informed consent is based in the duty to respect patient autonomy. Healthcare professionals are required, as both a legal and an ethical duty, to obtain informed consent from patients before administering treatment. Lack of informed consent is often the basis for a malpractice case. One of the basic tenets of informed consent is that the patient must be capable of making medical decisions. Most adults are presumed to have this capacity unless there is strong evidence to the contrary. An adult who is capable of making his or her own medical decisions must be given all the relevant information necessary to give valid informed consent. The information must be provided in a way that is understandable to the patient, and the patient must voluntarily communicate a decision to accept the treatment. Before giving informed consent, a patient needs to know the nature of the proposed treatment. This includes the purpose of the treatment and a description of how the treatment will be administered or performed. In order to give informed consent, a person also needs to know about the alternatives to the proposed treatment and the risks and benefits of each option. Physicians and nursing staff primarily have the responsibility of discussing treatment options and details with the patient and ensuring that the patient has a proper understanding of the medical treatment, associated risks, and benefits. Once the patient signs the informed consent, the document becomes part of the patient's legal medical record. If an adult doesn't have the ability to make informed decisions, that person is said to lack the mental capacity to give informed consent. Examples are an adult with a severe developmental disability and an adult with dementia. Typically, in these cases, another person is designated to make decisions for the patient. That person is called a surrogate decision maker. A child might have the mental ability and understanding to make his or her own decisions, but the law may deny them that right. In that case, the child is said to lack legal capacity to give informed consent. Sometimes an emergency situation is an exception to the rule of getting informed consent before treatment. For example, if a patient is unconscious and a surrogate decision maker is not available in a life-threatening situation, it may be determined that the patient has given implied consent to treatment. Furthermore, some experts say that the principle of beneficence requires that treatment be provided under these circumstances. One definition of death is the point at which vital physical functions cease. However, medical advances have made it possible to blur the line between life and death. Cardiac resuscitation has made it possible to restart a dead heart. Ventilators have made it possible to keep a body breathing after brain function has ended. There are a multitude of ethical issues about how death is defined and when an individual person can be considered dead. The next few slides look at two other prominent issues related to end-of-life care: medical futility and advance directives. Medical futility is the term for a situation in which a physician concludes that providing treatment would not appreciably improve the patient's condition. This decision is made by considering published evidence from studies of other patients and the physician's estimates about whether the individual patient would receive some benefit from the treatment being considered. Advocates of the concept of medical futility say that denying futile treatment is not healthcare rationing. The decision is not made by considering how much the treatment will cost, but rather whether an individual patient will benefit. The concept of medical futility is controversial for many reasons. Some people fear that the concept will be used to divert healthcare resources from disadvantaged populations. For example, some people worry that treatments could be labeled as futile in order to save money that would otherwise be spent on expensive treatments for elderly people in the last weeks of life or on patients who have a diagnosis such as cancer. People who support the concept of medical futility say that denying futile treatment makes it more likely that patients will receive the best treatment individualized to their situation. For example, rather than giving an expensive drug that is unlikely to save the life of a patient with late-stage cancer, a patient would be given hospice care to improve his or her quality of life until the end. This is another area where lines may be blurred between the movement toward pay-for-performance reimbursement, covered services by insurance companies, the patient's wishes, and clinical practice. Respect for autonomy is a core element of medical ethics. However, sometimes patients reach a point where they are no longer able to decide for themselves about their health care. People use advance directives to make their wishes known in advance if such a situation arises. Two kinds of advance directives are living wills and durable powers of attorney for health care. Sometimes they are contained in one document. The laws governing these documents vary from state to state, but the basic aspects are governed by a federal law called the Patient Self-Determination Act. In a living will, a person describes his or her wishes about life-prolonging care. For example, some people may say they don't want to be resuscitated if their heart stops beating, which is a Do Not Resuscitate or DNR order. Others may request not to be fed through tubes if they slip into a permanent vegetative state. In a durable power of attorney for health care, individuals assign someone else to make medical decisions for them when they are no longer able to. This document can be combined with a living will. For example, a living will might specify that the person doesn't want artificial feeding, but that all other important decisions are left to the judgment of the person named in the power of attorney. One of the arguments in support of advance directives is that they help preserve patient autonomy. In addition, it's argued that they can help prevent the waste of limited healthcare resources. Furthermore, proponents say that advance directives can help family members know the patient's wishes and help provide the family with peace of mind. Opponents of advance directives say that directives may make healthcare providers limit care inappropriately, leading to denying a patient potentially beneficial treatment. In addition, it's argued that some people are motivated by fear when writing a living will and therefore give unrealistic instructions. For example, they may underestimate their ability to handle pain or disability, or they may underestimate what their own will to live would be. It's also argued that powers of attorney can waste healthcare providers' time. For example, healthcare professionals may need to spend time finding the person who is designated to make decisions. According to a report by the Institute of Medicine, quote, "A conflict of interest is a set of circumstances that creates a risk that professional judgment or actions regarding a primary interest will be unduly influenced by a secondary interest." End quote. Primary interests include such ideals as ethical obligations and professional duties. Secondary interests are an individual healthcare professional's personal motivations. It's not wrong for a physician to make a fair profit or to want respect from peers. A problem arises only when these personal goals have the potential to compromise decision-making about a primary interest, such as the best possible patient care. An example of a potential conflict of interest is the practice of pharmaceutical companies giving gifts to physicians. Some researchers argue that even small gifts, such as pens and coffee mugs, can influence physicians to prescribe the company's drugs more often. One major area in which physicians face conflicts of interest is compensation for their services. Whether physicians are paid by the service or by the patient, their method of compensation involves potential conflicts of interest. When physicians are paid for each service they provide, they may find reasons to maximize their number of services. If they inappropriately provide unnecessary services, they are increasing healthcare spending at the expense of the patient and society. In addition, physicians might be motivated to select services with a high profit margin, such as diagnostic imaging, when it may not be appropriate. Physicians who are paid a flat fee per patient may be motivated to minimize the number of services they provide to each person. Compensation is just one example of the many kinds of conflicts of interest that physicians face in clinical practice. A topic of much ongoing study is healthcare disparities. It's well documented that, on average, middle-class and rich people receive better health care than poor people do. White people receive better health care than people of color do. And people who have no disabilities receive better health care than people who have disabilities. In addition, within each of these groups, there are differences in average overall health. There are numerous reasons why the health of one group of people differs from that of another group. One reason is that groups of people have different biological characteristics. Another reason is that people in one group may have higher rates of participation in potentially health-damaging activities. Exposure to unhealthy work environments or neighborhoods can also vary between members of different groups. In addition, there are differences in access to health care. A combination of factors can turn a difference in health into a social inequity in health. The difference must be systematic, socially produced, and unfair. How to address discrimination in healthcare is the topic of vigorous, ongoing debate. The term conscientious objection refers to a situation in which a healthcare professional has a moral or religious objection to providing a particular medical intervention. There have been numerous situations in which medical professionals have refused to provide medical interventions on the basis of their beliefs. In fact, recently some medical students have been refusing to even learn about certain procedures. The flip side of a healthcare professional's right to refuse to provide certain interventions is the right of patients to determine the course of their own healthcare. For example, if a woman who needs emergency contraception has access to only one pharmacy and the pharmacist refuses to provide emergency contraception, then patient autonomy is lost. Laws address the clash between the conscientious objections of healthcare professionals and the respect for patient autonomy. These laws vary widely among states. For example, some states have laws that protect the rights of physicians and pharmacists to refuse to dispense emergency contraception. Other states require these professionals to provide women with such drugs. Given the strong competing individual rights of healthcare professionals and patients, issues of conscientious objection are likely to be the topic of passionate debate for the foreseeable future. This concludes Lecture C of Ethics and Professionalism. In summary, healthcare professionals face numerous difficult ethical questions, including informed consent, end-of-life issues, conflicts of interest, healthcare disparities, and conscientious objection. Informed consent is based in the duty to respect patient autonomy and is one of the pillars of the physician-patient relationship. End-of-life care presents difficult questions about the definition of death, whether medical futility is a useful concept, and whether patients should be encouraged to complete advanced directives. Conflicts of interest can pose temptations for physicians as they attempt to balance their personal interests with their ethical duties. Health differences have many causes, and inequities require society-wide solutions. Conscientious objections represent a clash between healthcare professionals' rights and patients' rights. They are addressed by laws that vary from state to state and that continue to evolve.